So, good morning from here in Australia. Thank you and welcome to our first UDI webinar for 2023. I would like to acknowledge the traditional owners and custodians of the land in which we meet today and pay my respect to elders past, present and emerging. I'd like to extend that acknowledgement and respect to any Aboriginal and Torres Strait Islander peoples here today. So I'd like to now pass over to today's host, Gary Pascoe, the UDI Product Manager here at TGA.
Thanks, Rachel, and good morning, good afternoon, good evening to all of you who are joining us. We have some great registrations and interest in today's webinar, so hopefully everybody is able to join us that would like to. So as Rachel mentioned, this is the first UDI webinar for 2023, so I just wanted to sort of wish everybody a happy new year and happy 2023 if I haven't or we haven't spoken to you since the start of the new year. As you can see from the slide in front of you, this is our 15th webinar for UDI, and a large element of our focus to date has been predominantly around the provision of UDI data and the manufacturers and sponsors' responsibility in providing data into the Australian UDI database. We'll continue to have those conversations as the UDI implementation progresses and as we move closer and closer to the implementation date. However, we'll also start to be introducing some more flavours around obviously the value of UDI within the healthcare system and the implications and considerations for UDI within hospitals, healthcare providers, registries, other healthcare professionals. So a large emphasis of today is very much around bringing that to the fore and starting to sort of bring that perspective into the conversation for UDI. So I'd like to thank everybody for joining us and for participating in that conversation. I'd particularly like to thank Dr. Oliver Daley, as he's joined us to be able to sort of talk a bit about the UDI from a perspective of the healthcare system. And then you'll see on the slide there also Jasmine Hyatt. So while Jasmine doesn't have a speaking part today, a number of you will have been involved and engaged with Jasmine. She runs our UDI support team, help desk, essentially putting all the materials together. So I'd just like to welcome both Oliver and Jasmine to the conversation and to the meeting. So today's agenda is very much sort of twofold. As I mentioned, we'll start off with Oliver has kindly agreed to sort of presenting to us around the considerations and the benefits of UDI in healthcare. I'll also then follow that up with give you an all update on the UDI project and where things are at from a TGA's perspective and implementation of UDI. Hopefully answer some of the questions that a number of you have registered prior to the webinar as part of that process, and then we'll also set aside some time for questions and answers that you raise through the Slido app. So with no further ado, I just really wanted to introduce Dr. Oliver Daley. Dr. Daley is a practicing urogynecologist within the Western health system here in Australia. Oliver has been an active member of the UDI community within the TGA, and as you see here, he's been represented the co-chair of the UDI Triggers Working Group that we ran in 2021. Oliver himself has lived experience in terms of the issues associated with recalling devices and particularly critical devices in sort of medical crises and the issues and the challenges associated with doing that. So he's very much a supporter of the UDI and the implications of how that can support hospitals, and is very interested in sharing his experiences around how that can support and assist both from a clinical and an operational perspective within the hospital system. So I just wanted to welcome Oliver and thank you for your time and hand over to you.
Thank you very much, Gary, and thank you for everyone who's attending. So look, I'd particularly like to thank Tracy Duffy and Gary and the entire Australian Aus UDI team. This is a really important initiative. And hopefully I'll be able to demonstrate why it is such a fundamental element of the entire system for monitoring clinical safety and performance. I'm aware that there's a large range of stakeholders. We've got manufacturers, distributors, those who manage, stock in hospitals. There's financial aspects, but I'm going to be focused predominantly on those clinical aspects of how do we make sure that devices are performing in the way that we expect. So we'll just start with the problem that UDI really deals with. So until this initiative, there's really been no single universal identifier that exists for devices implanted into patients. And this limits the capacity of the health information infrastructure, so the health system as a whole, and any systematic processes to record and document device information at the time of implantation in a patient. And because we don't have that source of information, it's very difficult to identify, collate, analyze, and report devices that are used and what their performance is. And this creates a problem for all users of the health system, so patients, clinicians, and health system regulators alike. So how do we know which patients have which device, and at a product level and a manufacturing detail level? How do we know if there's a batch issue, for example? How do we provide feedback to clinicians about patient outcomes to inform clinical practice? Devices change all the time, and clinicians are using different devices. How do they know that they're actually getting the results based on the available evidence? And then for groups like the TGA, how do we actually, if we don't know the denominators for which patients have which devices, how do you ascertain the incidence of adverse events and the effectiveness at a population level, and therefore support those product safety and other evaluation processes to keep the Australian population safe? So I've got a few problematic device examples over the last 20 years or so. Some may know some of the lymphoma-associated issues with breast implants. And, you know, these are rare outcomes that it's only through you know, the breast device registry that they actually identified this. Because it's a rare outcome, you can't really identify it in randomized control trials. And so you really need large data and population level data to identify that. But then how do you, if you don't have a unique identifier that identifies that product, that breast implant, and the manufacturing details, how do you actually then do further investigation to further investigate that? We know about the metal on metal hip implants, and that there was a change in the design and composition of those devices that actually had significant safety and wellbeing impacts on patients and the performance of those implants. So once again, how do you actually track that back to a particular device or the manufacturing information? And then most recently, the issues with transvaginal mesh. As the Senate inquiry found, there was actually no way of knowing how many patients had a mesh. And because we didn't have those denominators, we actually didn't know, we couldn't really ascertain how big a problem those complications were. And so as we know, that has led to significant issues for women and patients themselves, but also clinical practice, in that there's, you know, we've lost a lot of products are no longer available because of these safety concerns, even though they might have been quite effective, but that's as a consequence of the significant impact on women. So what does a UDI system enable? So it enables this systematic prospective recording. What I mean by prospective is when a surgeon is putting a device in, they can put the unique device identifier into the medical record. And that means you can record it at a patient level. That means you can ascertain the clinical denominators at all levels of the health system potentially to look at device usage, safety, and performance. It also means that you can analyze those changes in device safety and performance over time. So for example, the metal on metal hip implants, that maybe you could have picked that up earlier if there were issues. You could link the device implantation details with other identifiers in the system. So the procedure that's being done, diagnosis, and then following up from that, any complications that might be related. So in the case of transvaginal mesh, you might have found that if we were recording this prospectively, that you could have seen that there were a group of women who suddenly were on chronic pain medications after their surgery. And so really it allows this analysis of outcomes both at the time of the implantation, if there's a complication intraoperatively or perioperatively, but also longitudinally over time. And then we can, and of course, ultimately we can support the role of health authorities such as the TGA when medical device safety issues are suspected, investigated, confirmed, and then it supports acting upon those. So if you have this unique identifier and the TGA sends out a product alert, they can look in their system and say, oh, this group of patients had these devices, and you can inform them and then advise further action. It may also be very useful for clinicians to know if there are certain devices that are not performing as expected, but also sometimes manufacturers and distributors don't know. So it also enables us to provide that complete feedback loop. So the UDI is critical to all of this. And how would it do this? Well, if we standardize, now I'm putting an acronym in so the high-risk implantable device. So all of these devices I've talked about are really these class 3 devices as per the classification. And so you could potentially standardize the UDI enables you to standardize the product information that is recorded by hospital staff. It's a single identifier that can be designed into hospital information systems and data collection processes. And that could be incorporated into other data sets, such as jurisdictional data sets and other clinical data reporting processes, such as registries. And then you can also incorporate into data linkage and periodic reporting processes, so that this may also support research activities. And down on the bottom right, you can see an example of a label that could be put on these respective devices to make it very easy for staff to do this. To provide a bit of background, the moment I knew that this was really important was some people may be aware of the federal court class action over the mesh devices, and we were mandated to do an audit of those to identify patients who had received devices. And through doing that, I realised that nursing staff routinely collect this data. They put it on, whether it's paper or electronically in the different health information systems, they record this. But the problem is that they're using a range of different identifiers to do that. So the purpose is really that it's very easy for the staff to know which identifier they should put into these systems to support these processes. So let's look at some of the challenges. So let's look at hospital information systems incorporation. So there are a number of ways that hospitals record data about implants. There are operating theatre information systems. There are patient administration systems that sometimes they're used for that purpose too, and also electronic medical records. And of course, some hospitals are still on paper. So you do need this needs to be implemented in a way that, irrespective of the way that implant data is collected, you can use the same UDI. And the really important thing is that you can support accurate, routine, and low effort capture at the time of implementation. If you can do that, then it's likely that you'll get a high ascertainment and high use of the UDI. We need to look at how do we replace existing device identifiers. So we have, there's ARTG codes, there's the prosthesis list code, which is used extensively in the private health system, and the national products catalogues for stock control. So we really need to look at how do we make sure that all of this is linked back and almost aliased back to that single identifier. And then the other thing we need to do is make sure the hospital is using the current UDI, because this may change over time. So aware that MBS has updates, the prosthesis list has updates. How do we actually disseminate that to hospitals? And that could be either a manual upload or machine-to-machine integration. But we do need to make sure that the hospital information systems are maintaining up-to-date, using the up-to-date version of the Oz UDI. Challenge 2. So where do we store and how do we extract this and use it for all the purposes that I've talked about? And making sure that it does support these regulatory quality improvement and research activities, obviously in a safe, adhering to all of the privacy principles. So some of the considerations are, should the UDI only be recorded in the patient record at a hospital level, so that you only look for it when there is an issue identified? And obviously retrospective analysis is that's going to support that process, but it wouldn't be prospective at a hospital, at a health system level. Potentially incorporate into My Health Record, so we do give patients implant cards, but often they lose them. So maybe actually having a digital record of that would be a good option. Is there a way that we have centralized storage in a specific register or data set to support linkage activities? So it is as a separate data set to the existing ones, or do we use one of the existing data sets, such as the jurisdictional administrative data sets? So in Victoria, we've got the Victorian Admitted Episode data set, and that feeds into the National Hospital Morbidity Database. So, and obviously if you have diagnoses, procedures, and the implant, you've pretty much got a complete data set. The third challenge I'll talk about is really reporting and data linkage. So if we do want to support using this data for monitoring, assessment, and reporting this device performance and patient outcomes, we really need to make sure we establish UDI as a minimum data set for important adverse events related to each of these high-risk implantable device types, potentially mapped to these diagnosis codes and the ACHI codes, which is the standard way of recording procedure codes in the National Hospital Morbidity Database. How do we incorporate this into data linkage methodology and the periodic reports that may be at hospital or jurisdictional level? And how do we then incorporate analysis, further analysis of this data, make it available so that hospitals can use it, the regulators can use it, but also clinical quality registries. And just putting this into sort of a bit of a flow chart of how such a system is really dependent on the Aussie UDI. So if we have this unique, if we have the UDI, we really have to look at the different aspects of that, about how it's used, and the various legislative and regulatory aspects of that, of making sure it's used appropriately and where that is stored. We'd have to look at the different hospitals, information systems, and do a current state assessment of where is this data currently stored through the different databases. And there are, as I've mentioned, there are a number of different databases that would use this identifier. What are the requirements of hospitals to use this information? What changes would you have to make to these systems? Remember, we have to have a really good relationship with vendors, because there's obviously a lot of development time and collaboration involved in making sure that the information systems actually can incorporate this data. And how do you make sure there's compliance? So how do you make sure that staff are actually using the correct identifier? And then there's the use of this information by health system users, regulators, and stakeholders. And then the use of this data, as mentioned, we'd have to review the data set options for where this information is stored. We'd have to look at these authorized users, who's permitted to use this routinely versus so ad hoc requests. How does this feed into the periodic data linkage reports, or perhaps related to adverse events? So if you've got an admission to hospital for a complication, how do we make sure that, how do we facilitate that being linked back to a certain device? So that's where these sort of minimum data sets come in. So if I'm performing an operation for a complication and it is related to a device, how do we incorporate that into the operation notes, so that then that goes into these data sets, so that we do have that complete feedback loop and can incorporate that into the data linkage. And then when we get into the analysis phase, how do we use that to identify the denominators and the specific rates? How does that feed into safety and quality assurance activities, and then also feed into other sources of clinical outcomes and variables? I've kept the presentation relatively short because I think it's really important that people do have an opportunity to ask questions and and further investigate, so that we can make sure that there are no other clinical aspects that.
Thank you, Dr. Daley. So really appreciate it. So as mentioned, we would very much encourage sort of questions, and I know there's a number coming through, and I think that the questions that have been asked really start to represent some of the things that and considerations that have been discussed here. So we'll set some time, as I mentioned, with the questions and answers at the back end of this session, and so we can address as many of those as we can. Before we do that, I just also wanted to provide an update on the UDI project and where things are at. So first of all, is the UDI project is progressing well and progressing nicely. And essentially, there's a range of things that we've been doing around just sort of continuing the work that was sort of completing or wrapping up at the end of 2023, and predominantly around a number of core areas. So the first one is obviously those of you who participated in the Sampit database and the testing of our trial version of the Australian UDI database. I'd like to thank everybody for that participation. And that ran from sort of 4th of July through to 31st of January. And I'll have a little bit of another following slide to give a bit more of a breakdown of what came out of that. But essentially that all closed on the 31st of January. And we certainly found that it was very successful. So as part of our sort of the next move within the sort of technical aspects of the Australian UDI database, we have moved the database and upgraded it to ensure that it is compliant within the Department of Health and Aged Care's IT environment. So that's essentially has occurred and is in the process of actually being tested and confirmed from a cybersecurity perspective, and essentially just making sure all those components are in place and operating with the intention of having what we're calling a pre-production version of the database available for use by manufacturers, sponsors, healthcare providers, or anybody else who is interested in from March of this year. So as I mentioned, the next stop point, we're essentially aiming to have this release occurring in March of this year for testing by all the range of different providers that have had access to the Sampit version. There are a number of questions you have asked around the implications for the Australian UDI implementation and the changes, or the recent changes that have just been approved by the European Parliament around their dates for the implementation of the UDIMED and MDR, and the implications of that for the rollout within Australia. At this stage, and obviously noting that this is subject to sort of final approval from the government and government direction, we're still aiming for voluntary compliance release in sort of end of April or May of this year, to be able to ensure that we can have a version of the database that reflects a sort of a production-like state that manufacturers, sponsors in particular, can have some certainty around the data requirements, the rules associated with the UDI database, and then obviously also then for hospitals and other consumers, other users of the UDI data, to be able to start to get a feel for what that data would be and how they could use it within the systems, per the conversations that Dr. Daley and considerations that Dr. Daley just put to us today. The policy is still in development, and so we have taken the feedback from the UDI consultation paper that was sort of closed at the end of last year, or October of last year, used all that information to formulate sort of policy position and advice to government, and that's essentially being sort of worked through and approved by the government. So we're working with within the TGA to sort of get to that point where we can provide some clarity and some certainty around the UDI database and also the UDI regulations. And I think there are a number of questions that have been asked sort of prior to this webinar around particular dates, which we'll come back and address. Unfortunately, are dependent on certainty of those, depends on final direction and confirmation or by the Australian government. From the UDI project, we'll recommence our technical working groups from the 28th of February, and with the sort of primary focus is essentially for us to be able to then focus on the provision and sort of finalise some of the questions that we had and work through with sponsors in particular around the submission of data into the UDI database. So they're confident that as the device is then supplied in Australia, the UDI information is available for use within the healthcare settings that Dr. Daley just sort of talked about. And I also wanted to sort of say our next webinar will actually be the 28th of March. So there's we've recently had a clash, so unfortunately there's an incorrect date there, and we'll change that before the slides go out. But our next webinar will be in March, end of March, and essentially looking at the focus on sort of continue some of these conversations around how that impacts, or how UDI impacts healthcare settings, healthcare providers, hospitals, etc. But also then looking to, at that stage, provide more clarity around what's happening with the UDI database, to set the pre-production version of that database, and ensuring that we start to make more consumers of the UDI more aware of what's happening from that perspective and implementation. So really then my sort of final a bit of a recap on Sampit. I know a number of you have participated and contributed to Sampit, and I just really, as I mentioned, it was open from the 4th of July We ran for 7 months. The original intention was to have Sampit open for 6 months, and essentially we extended that to the end of January. We have actually still operational, so from a technical perspective, if you have access to Sampit versions, it is still operational. However, with the pre-production version expected in coming weeks, in the next month, that we won't be admitting new users into that Sampit version, because there are changes associated with access and also for manufacturers and sponsors to be able to use the system. There are some changes. So rather than confusing everybody, we have closed access to new users, but we certainly will be opening that up again with the pre-production version. We did have 422 users, which is from original when we started this process. We weren't sure how many we would get, and certainly from our perspective, from a TGA's point of view, we've had very active support, and with 422 different users representing 177 different organisations, and as you can see in the slide there, 3/4 of those were sponsors or manufacturers, with a number of other sort of general public users who were interested in just understanding the UDI database. Now, general public user may have been, just as sort of somebody who was a consumer or a patient, or alternatively, generally represented organisations such as other government agencies, healthcare providers, hospitals, and other third parties who are interested in understanding the UDI data and getting a feel for what data is actually associated with the UDI record and the information that could be used to support some of those clinical processes that Dr. Daley talked about. We had 50 comments. Essentially, we had a whole range of other comments that came outside of that feedback tool and came to the UDI support team. They essentially had a whole range of comments around usability improvements, updates, and issues associated with the rules and regulations that we had in place. That ran in parallel with our last consultation paper, and that was useful in terms of providing us some feedback around things like the data elements, the data dictionaries, and the validation rules that were being applied. And so all of those comments effectively have been taken on board, looked at by the TGA's UDI team, with a large number of them in process of or have been incorporated into the pre-production version of the next database, or alternatively will be progressively implemented over the coming months before we finish our final rollout. So as I mentioned, just as a recap, so we're looking to have a new version of the UDI database for testing and access, and that was what we'll call the pre-production version, because it will be very much moving down that production path. It'll be sitting within Department of Health's IT environment, so that will give us the ability to do things such as validate ARTG entries with the UDI records. It gives us the ability to have users who are existing access through the TGA's business systems. You can use those logins and that access path to be able to access the TGA systems as part of that, the standard set of tools that you use today within the TGA's environment. There's a number of other improvements, such as the bulk upload. So we listened quite extensively to your feedback around bulk upload, and have made a number of changes per our sort of consultation before Christmas as part of the technical working group. So you'll look to see that in the coming weeks as part of our release as a very pre-production version. So we have moved through these topics as a really at a clip, and it's a good pace. So what we would like to do is then just invite anybody who hasn't raised any questions to put them into Slido. As you'll see, a number of questions actually have been moving along. We will sort of just have a bit of a moment to give you a moment to both do that in terms of put any further questions in. I did see that there was also the poll. Thank you in terms of the registration for the poll. So please, we would welcome your feedback in terms of using the Slido poll to give us a feedback around how we went, whether there was particular topics you were interested in. We'll use that to both shape and form how we deliver these webinars, but also make sure there's future topics are covered. Okay, so thank you, Rachel. So if everybody's happy, I might just sort of act as the master of ceremonies and sort of field the questions and work through them as we sort of work through, and then maybe answer them myself or hand them to Dr. Daley or others as they see fit and relevant. So there's a number of questions, and I'll sort of start. There's a number of questions we received in relation to the implementation of UDI within Australia and dates and timeframes, and particularly around the alignment with the European medical device reforms and the IV in vitro diagnostic reforms in terms of the regulations that they're looking at, and particularly with the dates of the UDI implementation. So, as I mentioned earlier, we are looking and still working through, subject to government approval, with the implementation of voluntary compliance for UDI. Provision of data and essentially then provision of devices with the UDI labelling on it from the 1st of July, or from May, June this year, and essentially be able to look the manufacturers and sponsors can voluntarily submit that data to the Australian UDI database, with the aim of having mandatory compliance for those high-risk devices. So, as Dr. Daley mentioned earlier, we have sort of class 3 and active implantables devices. We're looking to have mandatory compliance of those with effect or taking effect from the 1st of July 2024. So those dates are sort of still our target. The considerations in front of government are really the recent changes within the European timeframes and the dates that they're looking to roll out UDI within Europe, and ensuring one of the key requirements, or two of the key requirements for the Australian UDI implementation is ensuring that we're aligned with the Europeans and the US systems, ensuring that we weren't introducing additional regulatory burden that was above and beyond where we could in terms of the European dates, a European implementation, but also the European dates ensure that we were consistent and trying to create less impact as we could on the manufacturers and sponsors of those devices. So those sort of factors in terms of, I unfortunately aren't able to give you sort of specifics in terms of when those dates will be. It certainly is a consideration of government at the moment around the implications of the changes that really came through last week with the European Parliament around changes for MDR dates and how that would then be rolled out as part of the Australian UDI implementation. So certainly those dates are still working, are really driving all the work that we're doing, and is really as part of that process. I think there's a question that has been asked around whether when the legislation or the draft regulations will be available, and essentially we're still working to have those completed by certainly within this half of the year, and then available to manufacturers and sponsors and anybody else who's interested, to ensure that you understand what those implications are. And then as part of that process will be finalisation of those dates. So I will sort of answer a number of other questions associated with some broad questions. So first one is quite simply, we had a number of questions asking about can we get a copy of the recording and the webinar. So there will be definitely that information will be made available to the participants of this webinar, but also the TGA publishes that on its website once the webinar has been published and finalised, and that will be in coming weeks once we've closed this out. So from a number of other questions we had before the webinar around the such things as what is the basic UDI DI in the Australian database, and they sort of one of the responses say this was found in the one of the data sheets. This is referring, basic UDI DI is a concept that's being implemented in Europe, but won't be implemented within Australia. And certainly that's one of the areas that has, we've had extensive consultation with manufacturers, sponsors and industry over the last few years around whether the basic UDI DI concept within that the Europeans use will be introduced in Australia, and that's certainly something we can confidently say isn't currently in our schedule for introduction. Effectively, the Australian ARTG ID and the entry within the Australian Register of Therapeutic Goods provides that same sort of level of information that the basic UDI DI that the Europeans supply. So there was one question around, you mentioned the word universal when speaking of UDI. However, different countries may have different UDIs. Can you expand on how this will impact benefits? So there's definitely probably one thing, the term, if we did use the term universal, certainly that wasn't talking about from UDI. So the U in UDI is unique, and one of the key concepts of the identifier that's associated and attached with the device is that it is unique and it is globally unique. So essentially, as part of the UDI process, Australia will be complying and looking to comply with a similar process that other jurisdictions in Europe and US use around having an organisation such as the Health Information Business Communications Council, or GS1, issue a unique identifier that will, and those organisations as part of that requirement will be ensuring that that identifier is unique. It definitely, as this question raised, that there will be there's likelihood that those device identifiers or UDIs may vary for manufacturer in different locations, and definitely it will be, could be a situation arising where the same device may have different device identifiers across each jurisdiction across the globe. However, within Australia, it doesn't really sort of compromise or take away from the benefits of UDI. And as Dr. Daley talked about, it still gives us that ability to uniquely identify the device through the Australian healthcare system and realise the benefits around being able to quickly and easily and unambiguously identify the device and pull that device from within the healthcare system where it's being. So hopefully that sort of answers the question. I'll move to the next sort of question, which is the EU MDD and EU MDR transition will apply a UDI to imported medical devices prior to the TGA implementation. And really, I think this question is then said, will manufacturer format be acceptable to this TGA reform? And certainly I'm thinking, I'm expecting that is talking about both the device identifier that's maybe used by the manufacturer, but also the labeling that was put on the device. And again, while this is subject to final confirmation from government and as part of those considerations by government, the TGA Consultation Paper has certainly proposed that we released in at the end of last year, is looking to and has proposed, and we've had strong feedback in support of this, is to actually allow labeling and unique identifiers that are used in the US or the EU, to be used and accessible within Australia. So essentially a device subject to sort of the final regulations, looking to have a device that was manufactured in the US or manufactured in the EU, and if it's compliant with those EU MDR requirements, then we're looking to be able to accept that within the Australian UDI Australian system and then the UDI database. Obviously, we would be requiring the manufacturer sponsor to supply that data for the database, and there will be some Australian unique characteristics within that. Probably the best example will be the ARTG IDs. So we are looking to be able to link individual models of the device that a UDI reflect and indicate with the kind of device that and the application and inclusion for the medical device within Australia. So there will be a linkage. We're looking to be able to link the model of the device with the approval to supply the device. But essentially, that will be one of the sort of unique elements within Australia. But effectively, looking to be able to make it as simple and low burden for manufacturers and sponsors to supply that data. We have a number of questions on sort of patient labels and PICs, and essentially, so I might address a number of them together. So we've got this one here, which is patient labels and patient implant cards of high-risk implantable devices already exist and are in use with identifiers and serial tracking. And essentially, how will UDI be a greater benefit? So effectively, UDI won't be replacing these. So a UDI will be augmenting and adding to the patient implant cards and the labeling. So we will essentially, the requirements will be for UDI, this unique identifier, which includes both the model, the identifier of the model of the device, but also some additional information. And if the device has a serial number, it will be in that labeling to allow machine readable or human readable, a human reading of the label to ensure that information then flows through the healthcare system. And so one of the requirements will be, and as part of the implementation of UDI and the regulations, will then ensuring that the actual unique identifier is placed on the patient implant card as sort of part of that process. So as those who are familiar with patient implant cards, you'll see today there is a provision, or there has been a provision for UDI on there. And what we'll start to do once the UDI database and the UDI provision of data from sponsors becomes effective, and then that unique identifier will actually start to appear on the patient implant cards for activities and surgeries. You've probably had enough of hearing from me, so there was one question for you, Dr. Daley, which was, I'm happy to, if you're happy to take. So Dr. Daley, implantable today come with serial numbers. How would UDI change the behaviour of a clinician to start tracking information that exists today?
I suspect you just answered that question, that
Yeah.
actually the UDI will incorporate some of that serial number information, but I might have to throw to you, Gary, maybe to expand on how that will be incorporated. Yeah.
Yeah, thanks. Thank you. And I think I may have. So it's really as part of the sort of probably two things, the process that I've just talked about. So I suspect some of these questions have indicated to me that we may need to provide to some of the audience around what is UDI and sort of broader context of UDI and what comes in the device identifier. But essentially, at a high level, the device labeling, once UDI regulations will take effect, will require two identifiers within the on the label for the device, and they will effectively identify which uniquely identifies the model of device, and then another part of that identifier will also then be information about the production of that device. So whether it's a lot number, batch number, expiry date, or if the device is managed by serial number, the serial number of that particular device as well. And so essentially on the label, or all levels of packaging associated with that label will then have that identifier and that label, which can be machine or human readable, to ensure that as the device moves its way through the healthcare system, from supply into Australia, into a procurement or inventory system, and then through elements of the clinical system, to ensure that information can either be entered by particular administrative staff, or ideally be scanned electronically into the relevant systems that Dr. Daley talked about. You put your hand up, Dr. Daley?
I did, yeah. Just further to that, and I think it was what impact does this have on clinicians? Well, as I previously mentioned, this is information that is already recorded by often nursing staff in theatres. So it goes onto the operation notes, that sort of thing. So instead of, say, the prosthesis list number on the current with the barcode that's currently on the boxes, it would be the UDID sticker that we showed that could potentially go into those notes. So it should, if this is actually being embedded into the health information systems, then it shouldn't actually require any change in behaviour from clinicians. And if we can sort out how this information is stored, so that it can be extracted, if a clinician wanted to do a bit of an audit on the products that they use, then that's going to benefit the clinicians, but without adding excessive or additional data collection burden on them.
Thank you. Appreciate that. So I might move to another sort of questions that are related to this theme around the impact on hospitals and facilities. And there is one question sort of says, how many hospitals facilities are signed up to test the Sampit? I couldn't actually tell you specifically on the number. We have had some, but it is early days. The project, the UDI project, is conducting a number of early adopter trials and projects with some state-based healthcare systems. We are starting to talk to private healthcare providers as well to ensure that we understand the implications. Because as Dr. Daley mentioned, there are different states of maturity. There are different technologies and IT systems used within the hospital setting, and obviously then we're looking to say, how do you incorporate UDI within those, and how does that change your work practices and what you do? And obviously that is likely to be unique to each location, each facility, and particularly may even be particular theatres or clinical practices within those facilities. So we are starting to work with and looking to work with software providers for electronic medical records, patient administration and procurement, particularly around electronic health systems. And so essentially be able to ensure that those systems do incorporate the UDI as part of a sort of an identifier that flows through their particular technology. So that is still early days. As part of that conversation, so we're working with a number of other organisations within the healthcare sector, and particularly within government, such as the Australian Commission for Safety and Quality in Healthcare, and other state healthcare providers and other sort of government sections within the Department of Health and Aged Care to ensure that we can make this UDI implemented across the healthcare system as simply and as quickly and easily as possible. The unfortunate thing is the TGA's responsibility from a regulatory perspective is that we will regulate the supply and of the device and ensuring that the device, when it's supplied in Australia, will meet the UDI requirements in terms of the labelling and the data provision. But there's then a whole range of other requirements within the hospital and healthcare system that steps outside of the TGA's remit. So the TGA, there was a couple of questions about how does the TGA mandate this to come forward. Essentially, this is part of this process now to show the benefit, but the TGA doesn't step that far. There was another question that sort of came to mind around that I did see earlier, and it's around there's sort of the protecting privacy and ensuring patient information wasn't shared. And if off the top of my head, I think the question was effectively saying UDI is a global initiative, and if there is sort of sharing of UDI globally, then how do we protect patient information? I sort of just wanted to stress that the UDI itself is actually the UDI database, and the database that the TGA is developing does not contain any patient information. It's essentially storing the attributes and the information about the device. So the unique identifier is a key, and then as the attributes are about the device, and that is all. That information is then shared or being accessed by whoever's interested in using that information. But the TGA is now not collecting anything to do with patients, medical records, or any sort of clinical practices that then we feed back into the UDI database. So essentially that identifier, that the UDI key, is then shared and can be accessible by anybody in the healthcare system, or any hospital, registry, healthcare professional within the healthcare system. But all of that association with patient records in particular is all still managed within the systems that sit within the hospital, within the registry, or within the sort of the personal record systems that you have. So there is none of that sharing. So there's no issues associated with patient information being shared through the UDI database, and that's not something we sort of cover. Dr. Daley, you had your hand up.
Yeah, I just want to clarify. Yeah, so when we talk about centralised storage of patient information, for those who don't know, obviously all of the statutory mandatory data sets that hospitals have to provide, so the admitted episode databases, data sets that also contribute to the National Hospital Morbidity database. So there is obviously patient level information in a lot of these, but there are very strict governance processes over how that is used. So I guess one of the considerations I was putting forward is that given all those protections that exist with those data sets, that one possibility is that you add an extra data item, which is actually one of the Aus UDI, so that you can do that data linkage, particularly in the high risk devices where it is really important that we make sure we identify any potential issues. So I think particularly there was a question that said centralized storage of patient information and UDI being international. And it really comes back to your point that it's the device identifier that is international, or in this case, an Australian identifier. It's not the patient information that, if that makes sense. So Gary, there was one other question that I wanted to draw on that's been sort of waiting there for. Was I think somebody asked, how will hospitals be made to comply with minimum data collection requirements for the UDI? Are you happy if we answer that one?
Absolutely.
Right. There's quite a lot of interest in that question, understandably. And all the questions have been great, actually. My presentation was really presenting some of the key considerations, but they're certainly not all the considerations. So I guess the reason I told the anecdote about how device information is already recorded in the system, the problem is that a whole range of identifiers are used. So it's actually impossible for groups like the TGA to actually go back and identify if there's a problem device, to actually go back and do a retrospective look back. It's quite a lot of work to identify a specific device or batch number. So that work is already done. So I actually don't think it's necessarily that hospitals would be made to comply as such, because they do this already. And this is why I drew on the fact that we want to make this as easy as possible to actually use this identifier in place of the existing ones that they use. So I think if we can, if you can meet those two criteria, make it easy and incorporate into the existing data collection processes, then they're the two biggest enablers of this being effective.
Thank you. Yeah, and I appreciate that, Dr. Daley. It's really important in terms of understanding that. So thank you. I will actually, unfortunately, draw this to a close. We still have about 30 odd questions I can see that still have to be responded to. So I'd just like to offer my apologies for not able to get to all your questions. Fortunately, we're about to hit time. What we will be doing and what we will do is we'll take all of these questions, collate them, and provide responses back to the group, and we'll actually include that as part of the wrap up as the publishing of this webinar onto the TGA website once we sort of finalise and wrap all that up. So we'll make sure that we'll address all of these questions. We may take a number of the questions that are common themes and address them collectively, but definitely looking to ensure that we have a written response to all of the questions you have asked. If you may just flick back quickly, Rachel, or whoever's in control, to essentially, we also welcome your feedback on any other questions that you may be asking to our UDI support team, as Jasmine has definitely willing and very interested in taking more questions. udi@health.gov.au is the email address. So thank you very much for just that, Rachel. And then finally, then there's some other links in the pack that on the next slide that will provide some additional information around what we're doing here in Australia. Those of you who aren't familiar with UDI, I sort of recommend probably the first two. Go to the UDI hub on the TGA website, as well as then if you are a little more familiar with understanding what some of the features of what we're proposing for the Australian UDI system, I recommend you looking at the third UDI consultation paper, which is the second row on that website link. So again, I would just like to thank everybody for your questions. Really appreciate, and certainly, as Dr. Daley has mentioned, we're sort of looking at this to start to elicit further questions and understanding about UDI, and really want to thank you all for raising that. And also particularly wanted to thank Dr. Daley for spending the time with us today, getting prepared. I know you have a very busy schedule, so taking this time out to prepare and get us going. So I would like to thank you very much for your time. I wish you all a very happy rest of the day or evening, depending on where you're coming from, and look forward to talking to you all again on the 28th of March. Thank you.